All right, thanks everyone for coming back on time for the pulmonary embolism session. With me on my panel, esteemed group of colleagues. Next to me is Dr. Sam Horr, Dr. Tarek Hammad, Dr. Zach Rosol, and Dr. Brian Stegman. So without further ado, let's jump into the first case. Dr. Castro from University Hospitals in Cleveland Harrington Heart and Vascular Institute will be presenting a case of acute pulmonary embolism with a failed pharmaco-mechanical lysis.
Great. Thank you so much. Good afternoon. So I'll be talking about a case of failed pharmaco-mechanical lysis, or as I want to try to get a little bit of credit, maybe partial success or failure of a thrombolysis case. These are my disclosures. So this is the case of a 41-year-old woman with history of morbid obesity, a BMI of 58, active smoking, prior opioid abuse, brachial artery thrombosis, and compartment syndrome needing a left upper extremity amputation, prior unprovoked DVT, PE, hypertension, HFpEF, COPD on oxygen, lower back pain, so multiple comorbidities, as you guys can see, that is coming in with shortness of breath for a week. Given her history of multiple thromboembolic events, she was previously advised to be on indefinite anticoagulation, but has not been compliant with Eliquis recently, has not followed with specialists, and overall multiple barriers to access to care. At her baseline, she's only able to walk only from bed to the door of the room. When I evaluated when we talked to her at her house, she was only mainly able to walk around her house. Normally, she needs to stop due to shortness of breath for multiple years, mainly uses a wheelchair to move around. So the fact that she's coming into the hospital now with shortness of breath, I mean that there's a significant limitation in her symptoms. It's at baseline, she doesn't do much. Okay. On presentation, heart rate, she's tachycardic, heart rate in the 120s to 140s, normotensive, okay? But she's requiring a lot more oxygen than she requires normally. She's on high flow nasal cannula, 50%. Elevated troponins, elevated BNP, just borderline lactate. If we calculated her PESI score, BOBA score, intermediate to high risk, and overall 42% risk of PE-related complications if you look at her risk score. So overall, we're looking at an intermediate high risk PE. Presentation in her case, reason why we're evaluating for what else can we do for this patient who's overall has a lot of comorbidities, morbid obesity, limited symptoms, has been on anticoagulation, just an admission, but still requiring high dose of oxygen. So this is her CT, as you guys can evaluate. So there's a saddle PE, high clot burden overall on both sides. And as you guys can see, her body habitus as well, which is can be, an overall big cause for shortness of breath. This is her echo, severely dilated RV. There's likely some chronic component to it, but definitely with the elevated troponins, we think there's some acute as well. As you guys can see, the areas of hypokinesis as well. So large RV with some dysfunction as well. So our initial management, we do IV heparin for anticoagulation, therapeutic range first 24-48 hours, evaluate if she has any improvement in symptoms. However, she continues to remain tachycardic, heart rate of the 120, 140s. That was the main thing that was concerning to us, still pretty tachycardic, needing high flow nasal cannula, feeding short of breath, although some improvement, and unable to lay flat at all. And this is multifactorial due to likely this presentation, also due to her chronic lower back pain. So with this, I just want to leave it up to the panel first. I want to ask you guys, what would you do next with this patient? What would be your approach?
How long ago was the arterial?
Many years ago.
Thrombectomy?
Yeah, over a decade. Mm-hmm.
I mean, she's clearly in the intermediate high risk category. There's a component of chronicity, like you said. She's got relative contraindications, you could argue, for lytics, but if she doesn't have an emergent one, immediate one, with her body habitus, you're concerned clearly about any large bore catheter therapies as well. So I mean, I think she's one it'd be reasonable also to consider half dose lytics or full dose potentially.
I think, like you said, it sounds like a large lady. I also worry about some chronic pulmonary hypertension. So this is not someone I'm really excited to maybe do large bore thrombectomy on. This is someone that I don't do a ton of catheter-directed lytics, but this might be someone I might take the Bashir or Ecos or whatever your catheter is and do that therapy.
So I agree with what's been said already. I think part of it, you have to consider whether or not the tachycardia is from the underlying obesity as well. It would be important for us to understand what her trends are as an outpatient. And obviously, patients that are morbidly obese also have some form of pulmonary hypertension owing to the obesity. So the RV dilation itself, as you mentioned, may be more chronic. However, I think the troponin and the elevated BNP speak to perhaps a more acute nature as well for the RV. I think what was profound was, especially in the CAT scan, you can appreciate some left ventricular hypertrophy. And the RV itself on the CAT scan looks huge, but then when you look at the echo, it's kind of just mildly dilated with some decrease in function. So I think there is a slight discrepancy on the CT versus the echo, primarily because of her LVH as well. So it's something to consider as you're going through the workup for these PERT patients.
Definitely, thank you. Great thoughts. So things that I'm considering, knowing that there may be that she's had prior events in the past, and maybe some chronicity potentially to this, although there's some, definitely a change in her symptoms at baseline. I'm concerned about her morbid obesity, body habitus, risk of complications with a large bore axis. Another thing that I'm concerned, these are the patients that I truly think, I don't do a lot of lysis, but these are the patients that I think might benefit potentially a little more from lytics, is because if there's some underlying chronicity, potentially lytics can help more with the distal disease overall, can help more with improving the distal perfusion. So these are the patients that I tend to evaluate whether they would benefit more from lysis compared to large bore thrombectomy. So this is what we decided to do in her case. So we elected to do 6 French ecos in bilateral pulmonary arteries via right IgA approach. We placed 2 sheaths from the right IgA approach. We're open in hemodynamics, RA of 18, PA systolic pressure of 90, and a mean, pretty high pressures, and a mean pressure overall pretty elevated of 62. Cardiac output and index was 5.9, 2.2, so borderline overall cardiac index. So overall, this talks to me about somebody with chronic pulmonary hypertension. You do not get these pressures from an acute PE. Okay, so definitely likely some acute on chronic disease. So this is somebody when I'm definitely considering maybe they might benefit more, as well as I mentioned, from analytic therapy. So we like to do 1 milligram per hour of TPA for 12 hours. At 12 hours, still tachycardic, but feeling improved, but still with a high O2 requirement. And therefore, we elected to continue lytic therapy for another 12 hours. So you guys can see that's our approach with ecos. After 24 hours of lytic therapy, patient feeling significant improvement near back to baseline, still requiring 45 liters of nasal cannula, so almost near to her baseline. Heart is still tachycardic, but the RV, definitely the function is a little bit of improvement. So this is where I want to ask the panel. So this is a little bit of what we did. Just after this 12 hours of lytic therapy, would you guys have continued to do more lytic therapy for another 12 hours? Would you have elected to do large bore thrombectomy? What would be your approach when you're having your patient after 12 hours, a significant amount of time with TPA? What would be your next step?
It's interesting. Actually, before we move to that question, for somebody this morbidly obese, certainly you have to consider whether or not the dose of TPA is sufficient. In addition, how do you manage the anticoagulation while the patient has these catheters indwelling?
I probably wouldn't go and do large bore thrombectomy still at that point. You have some objective improvements where you're near your baseline from an oxygen perspective. Maybe a right heart cath would help guide you to see if your PA pressures drop some, but you obviously have a significant component of chronic thromboembolic or some type of long-term pulmonary hypertension going on here. In our experience, sometimes the heart rate can be the last thing to improve, especially in some of these subacute presentations. While we have other objective measurements that are there, it just takes a little bit for the RV to kind of calm down.
Yeah, I think in addition to that, this is a woman who's on a lot of oxygen chronically. She very likely has some degree of resting tachycardia generally. So if you're seeing clinical improvement, then I think time is the best medicine sometimes. You can always rescan people too. We do that every now and then. You don't have to do it very often, but every now and then you can rescan and just understand what the clot burden still is.
I think the oxygen requirement, I didn't look back at the CT, but if she had pulmonary infarcts, that would be the other thing. If,
It
likely
looked like
it's
she had a
pulmonary
little
infarcts,
bit in
then
the.
She did.
Yeah, so the oxygen requirement's going to take a while to come down, and so I think the idea the oxygen hasn't improved yet isn't so concerning to me that I would jump to do thrombectomy.
I agree. I would give her more time. Yeah, anticoagulation and let the medicine do the work.
I probably wouldn't have done the other 12 hours. Honestly, we don't do 24 hours of CDT very often. I don't know what other people on the panel would have done. I probably would have stopped at 12 and then just did anticoagulation. But
Do you guys have the 8 French catheters? Or are you all 6 French still?
We only had the 6 at this moment, but
Yeah.
have you seen some?
I know that the word is you can sometimes do 2 or 4 hours. We still usually routinely do 12. Yeah.
Yeah, I don't think we've personally done enough to know if there's truly a difference between the 6 and 8 French kind of clinically. Yeah, I agree with Sam. I probably would have just stopped at 12 and, but certainly they clearly got a good result by going a little bit further, right?
And this is where, with the era of thrombectomy, where we can see the changes on the table, where you would get a little nervous, or not a little nervous, but you feel like, okay, what else can I do for the patient to get her to improve? And where you wonder, okay, doing another wire cath, doing imaging again, what else can we do in order to prove that our intervention has worked? Generally, because we use the signs of checking again the pressures, intra-procedure, or just seeing the resolution of the clot, but that's the things that we cannot see immediately with Lysis.
So in the HiPitho trial, the protocol is actually essentially to give the lytic on table first and then indwell. That would be something to consider in somebody this morbidly obese, is whether or not you need a bolus of lytics before you initiate the drip. In addition, there are some studies out there with the Bashir catheter actively enrolling right now, where we do on-table TPA and essentially monitor for improvement in PA pressures on table. So that's something to consider, perhaps a larger dose of TPA before you start the infusion, and perhaps that would have shortened the additional 12-hour duration. I think, at least personally myself, I've moved away from a standing dose heparin for anticoagulation, and I do actually systemic dose heparin, especially in somebody this morbidly obese.
Perfect, thank you. So as I mentioned, after we did an additional 24 hours, we saw some more significant improvement. Our concern is, she was still having a high requirement. That's why we proceeded to doing a little more therapy, but we see her TAPS improve. That means her heart rate function improved as well. And she did have a repeat CTA before discharge, where we see there's still some clot burden. What are people's thoughts when we see the CT?
I still give it just time. As Brian said, I think time's sometimes the best therapy. I mean, the RV looks back to normal. That RV to me looks normal, function completely, and she has some flow around the clot. I just give it time with the anticoagulation alone.
I think lytics, your goal is not necessarily to get rid of the big, bulky stuff proximal, right? You're trying to clear up the distal stuff to improve perfusion. And so the RV, I think you said the clinical's getting better, the RV's getting better on CT. I think you just do time.
Yeah, I agree with that. The CT looks like the perfusion's better. The right lung looks like it's getting a little bit better contrast, and there is that infarct that you can see in the right base, and I'm sure that's affecting things as well. The other thing that is not something that's ever talked about, but that you end up having to tell people a lot is, incentive spirometry, anti-inflammatories, stuff like that for the infarcts actually often does more than what you're doing for the clot.
Perfect, thank you. So yeah, after the CT, we decided to continue to manage her with anticoagulation alone and monitor, and hopefully that she kind of will improve with anticoagulation. So we did, after 48 hours of IV heparin, patient feeling significant improvement, back to her baseline oxygen requirement. Heart rate did improve, thankfully. We were able to bridge her to warfarin given her BMI, and hopefully follow up with a pulmonary hypertension clinic. So key learnings from this case for me were, with every potential intervention, consider the risk-benefit ratio, the patient's baseline quality of life and functional status. This was a patient that definitely were not going to get her, I was at least trying to get her closer to her baseline. I knew that she was already limited in terms of her functional status. And the question is, what's the role of redo imaging in catheter-reducted lysis? Should we be doing this a little more often or not? Should we do it in all patients or only if symptoms persist? And when do we stop further CDL or CDT? Is it based on the clot burden, hemodynamics, or symptoms? So those are things that we should definitely evaluate when we have our protocols in order to decide what to do with each patient. Thank you.
Up next, these all sound very negative, but Dr. Rosol is going to show us a case of failed mechanical thrombectomy. He is at Baylor University.
Great, thanks. I appreciate the opportunity to be here and to be on the panel. I thought the last discussion was great. I'm excited to hear what you guys have to say about mine. So here we go. So no relevant disclosures. This is a 64-year-old woman with, she's had unexplained anemia, she's had an extensive workup, requires transfusion. She had 2 weeks of shortness of breath and then was going to go pick up her grandkids and syncopized while sitting in her car, and that's where her daughter found her. A little confused, dazed, hadn't left the driveway yet. She called EMS, was brought in, can't talk. She's very dyspneic. Here's her vital signs you can see and some of her initial lab values. Here's her CT scan. So what you'll see is there's large thrombus burden bilaterally. There's not a true saddle, but we have very significant obstructive, rather acute looking clot as well, that circular clot that doesn't appear crescent and adherent to the wall. You also, I'd point out, you have, which one's the pointer, guys? Anyway, there's reflux into the IVC as well. All of these are signs of significant acute strain on the right ventricle. Okay, so with her clinical picture, our decision was to bring her to the cath lab for mechanical thrombectomy, especially with that syncopal event. Would anybody have given this person lytics, or would we do thrombectomy?
I think thrombectomy in this case. I think the one concerning thing, the lactate's normal, is that your shock index is high. So if, shock index I use frequently. It's very simple. Is your heart rate higher than your blood pressure? In this case, it was exactly equal, which to me is always a bad sign. So
we always get worried about the people that have a syncopal event as well. I know it's not a part of a PESI score or anything like that, but I mean, if you syncopize for a reason, something happened, right?
Yeah, I 100% agree with you. Syncope is pre-death, right? So that's at least how I always think about it. And so those are patients that you need to be a little careful with. I think from a clot burn perspective and position, this looks like a great mechanical thrombectomy case.
Yeah, that's what we felt, and that's why we felt we could get her out of that trouble window faster, take her to the lab, and move the process along. So here we go. So going up initially, take an initial angiogram, you can see that clot burden. This is, my practice is we go up with the catheter. I already look at the CT scan. To me, the coronal image is really important to locate the clot burden. So I go up and make a first pass, and then I take an initial image after that. So this is my initial image after the first pass on the left. You can see we still have pretty significant residual clot in one of those lower segmental branches. So I pass the catheter down again. That's just a still shot image of where I've took that catheter. And then here's where we're at. Cough, cough, cough. Anybody that has coughing on the table always makes us nervous, right? Anybody see it? Shout it out if you see it. Because we saw a lot of the blood that was coughed out and on the floor all of a sudden.
So the only question I have is, at least your first couple of pictures were all without a wire. And so...
this is a penumbra device.
It's a penumbra.
This is a penumbra, so we take it up over the wire initially, and then after that we drive without,
It's 18 French, is that correct?
This is a 16 French. So I usually put an 18 French dry seal in. I'll draw your attention to the upper left portion of this image where you can see the esophagus that highlights in contrast. Okay, this is an image I hope nobody else has to see, but that's why I kind of wanted to share it here. So this is frank, massive hemoptysis because, where's the pointer on this? Which one's the pointer? Very bottom one, there we go. Look up here. You see the image of the esophagus and the contrast going up the esophagus, okay? When we saw this and we had massive frank hemoptysis, obviously this is a butt puckering moment for everybody. So a couple pointers. Remember, we're driving large bore catheters. There is a penalty to pay for that. While we most of the time get away with this and it is the right thing to do, remember, these are large bore catheters. There are potential complications with that. So, okay. So you have massive hemoptysis. So what do we got to think about? Is the airway compromised? How bad is it? Is it just a little bit, okay? Or do we need to take more invasive steps? This was frank, significant hemoptysis, okay? So we quickly, with that patient still on the table, we rolled them onto their left side to help perfusion, and we ended up emergently intubating them because of the amount of hemoptysis that was happening, okay? So good lung up, have your anesthesiologist selectively intubate into the right main stem, okay? And then you're rallying the troops. You don't know which way this is gonna go. You're gonna hope that's something that you can temporize, but if not, you need to be ready to support that patient, okay? So you need to be getting arterial and venous access contralaterally if you don't already have it, okay? We are a center that has ECMO, so in case we had massive hemodynamic collapse, we were getting them ready to the bedside. We weren't gonna commit to cannulating yet, but you need to be looking at emergent transfusions as well. So, and then you gotta think about, why did this happen? Did I perforate with a distal wire, potentially? Is this a reperfusion injury? Or is this just something that is a large bore mechanical complication from one of these branches? And we know these all look straight vessels when we look at the angiograms, but remember, these are 3D structures, so it's very possible we manipulated the catheter too much and we led to some type of laceration that led to massive damage. So how do you deal with this, right? Well, I knew where I had driven the catheter last. That's why I showed you guys that picture in that left lower lobe. So very quickly, what you can do to temporize locally, just like you would in the coronary space, take a wedge catheter or a swan with a balloon tip catheter and advance that very fast over an atraumatic wire into that area and just balloon tamponade, okay? That can temporize this very frequently, okay? And just leave that up. We don't reverse anticoagulation right away. And then either in your secondary access, or we all have a large bore access, you can put another imaging catheter up. So we brought a pigtail up as well, just to better understand here. So you can see this is an image with the pigtail with our wedge catheter here, lower in the area. We don't see any obvious hemoptysis here, and we're selectively intubated into the right side. There was still a lot of significant blood coming out of the ET tube at this point in time, and so even though we didn't see obvious hemoptysis, the other thing you can do is you can try to tamponade further. Okay, so this is a large 22 millimeter balloon. We bring that over an 0.35 wire, we put it in the left main stem, and we tamponade for about 5-10 minutes here. During that time, thankfully, I have a great pulmonary team. They were able to come and do a selective bronchoscopy into that area as well, because remember, they can balloon from the inside, okay? We're on the outside trying to stop the inflow. If you have damage, or if they can locate the area in the airway, they can actually go balloon tamponade through a bronchoscopy. So we had them come and call. They couldn't find it. They could see where the blood was coming from. They couldn't find an obvious source. So we had them just place a wedge in that, balloon wedge in that area too. So rally the troops is the moral of the story here, okay? So again, if this happens and you have frank hemoptysis, think about why. Is it a distal wire perforation? Are you using the 1 centimeter tipped, what I call the spear, the Amplatz, 1 centimeter tipped Amplatz wire, okay? Is it a large bore perforation where you need to tamponade more proximally? Also, in some of these subacutes, what I've learned from my pulmonologists, the lungs do a great job of shunting everywhere, and they start to compensate really quickly. And so if you have some of the subacute clot, you all of a sudden pull this off, you can get a massive reperfusion injury as well, okay, which is just the alveolar space and all the capillaries becoming overwhelmed, and with flow where they pretty much burst temporarily, okay? That's what my pulmonologists think may have happened. I think I probably caused this with the amount of hemoptysis, but that's a possibility as well. The steps to help maintain this: take a breath, go back to your basics, right? Maintain the patient, make sure you have a secured airway, get ready to deal with the complications as well. Locally tamponade with a wedge catheter often can be enough, okay? And if you need to tamponade more proximally, it's important that if you're going to do these, especially this intermediate high risk, I suggest having a larger balloon either on a cart or in your cath lab right where that is so it can quickly be grabbed. And just like in the coronary space, you don't always need to reverse anticoagulation right away. Remember, you have a large catheter and you're already dealing with a thrombotic state. We don't need more thrombus to create thrombus in transit as well. And just so everybody can sear this image into their mind. Remember, these PE patients are sick. They're sicker than most of the STEMIs that we have coming in. So treat them respectfully that way. Be ready for complications. Always do your quick PA pressure and get a SAT so you can help to quantify this. And as was well demonstrated in the last case, some of these people have chronic thromboembolic or chronic pulmonary hypertension for other reasons, and be very cautious with those patients. I'll stop that.
A couple of comments. So I think it's so important to recognize that we are dealing with very sick patients, and the pulmonary artery vasculature is not the same as arterial, like normal systolic arterial vasculature. They're very fragile. I think this case clearly demonstrates patient selection is important, and technique is very important. I think certainly as more and more new devices come up, they're gonna say you can advance this without a wire, et cetera, et cetera. Maybe I'm old school. But I actually think even with a medium bore device, one needs to be very vigilant about careful advancement, particularly over a wire so that you're tracking into the true lumen. How did the patient do?
Not well, unfortunately. We actually, they had a very large clot burden in their left leg still, and they kind of had a bad case of the dwindles in the cath lab. They didn't completely decompensate. We made the decision that it was still probably safest because with her blood pressure after intubation, everything was in the 80s, that we felt it was best with her hemodynamic state to put her on ECMO. When we were I asked our people to be careful, and as we were advancing the venous sheath in her left groin, there was a lot of resistance, and I was concerned about May Thurner. Once we got her up to the ICU, her hemoglobin was like 4, but it wasn't coming out of her ET tube anymore, so we scanned her. She ended up with a massive RP bleed on the left side, which was not the side of her arterial cannula, so we probably perforated her May Thurner vein. She improved from a hemodynamic perspective. We brought her back, we stented that left vein, we cleaned out her right lung at the same time that we did that, and she actually improved. And when we went to take her off of ECMO, the surgeons were doing the decannulation, she just kind of kept having that ooze. Her platelets were like 70,000, and she just kind of oozed and kind of bled out at that point. So she unfortunately did not make it, probably from complications after. So I'm kicking myself whether we really needed the ECMO or not, but hindsight's 20/20. Yeah.
That is Shishehbor.
Mehdi, yeah.
One of the things that we experienced, first of all, thanks, Zach, for showing that case, because I think we learned a lot. One of the things that we experienced is when we started doing CTEF work. And, when I traveled to Japan, over 10, 12 years ago, and I spoke to those guys, one of the number one complication was hemoptysis. And they did, all the studies they did, they showed that a lot of the hemoptysis, majority, was from the guide. And the guide they were using was actually 6 French. So I think that, learning a little bit from that even a 6 French guide, because the pulmonary arteries, especially as you go more distal, they're much thinner. They don't have the thickness of the aorta. And I think that using catheters without the wires, these guys, 16 French, 18 French, 20 French, 24 French, without the wire, you're asking for trouble, because these are end-hold catheters, and the likelihood of even some tear, and it becomes even difficult to identify them, because if you have a wire, we've seen it with Swan, for example. When we have a Swan perf, it's easier to identify. When you have these dissections, it becomes much harder to identify where the location is and to be able to deal with it. Just a comment.
One more quick comment for Zach. That was awesome. It's hard to get up and talk about complications, and it's something that all of us should do more of. The patient outcome, unfortunately wasn't great, but the way that you guys worked through a perforation algorithm, was perfect. And I think having everybody be able to see that is invaluable.
I appreciate that. That's why I wanted to present it here, because you're right. Things happen, and if I can help the next person get that person off the table, then we've helped someone else.
Yeah, great case. Echo everybody comments, but back to more to the wire point that Jun and Dr. Shishehbor brought up. I think also not just prevent injury. I think having a wire in, if you truly have a distal wire perf, help you maybe walk a balloon over that wire, so you know exactly where to go. So I think that's another advantage of having a wire in. And it's like everybody said, I think it's key not to advance catheter if you don't have wire, etc. But I agree, great case, a great, learning points here. Thank you.
All right, thank you, Zach.
A couple questions from the minutes.
Thank you for that great case. Just a quick question. How long do you keep the balloon out?
Great question. I would do it at least 5 minutes. Especially if you have a wedge catheter up, you're selective with your wedge catheter. You're perfusing theoretically the rest of the lung. You still have the right lung that's has some perfusion to it. But there's not a perfect science. But I would say, especially in a vessel this size, I would do 5 minutes. Catch your breath. Make sure your airway is secure at this point in time. Take the balloon down, leave it right there, and take another picture and see.
Good. And one thing to add, keep in mind that about 3 to 5% spontaneous, hemoptysis. So not every hemoptysis in the cath lab table is a complication necessarily. But the great point that we wrote guys interventional pulmonary because they bronched and they saw blood coming out, right?
Yes.
Yeah.
Yep.
All right. Thank you, Zach. Next, I'll invite my co-moderator, Dr. Sam Horr, up from TriStar to discuss acute PE failed systemic lytics.
Thank you, Sam Horr. I live in Nashville, Tennessee at Centennial Medical Center, and I get to show a failed lytic case. So these are relevant disclosures. So 54-year-old male, the diagnosis is not a mystery, but 54-year-old male came in with a couple days of malaise and shortness of breath, had an episode of syncope while using the restroom. Notably in his past medical history, you'll see is other hypertension and hyperlipidemia and tobacco use, which is everyone in Tennessee. Also has type 1 diabetes. So on arrival, he was tachycardic. Blood pressure was okay, a little soft, not hypoxic, interestingly. So 99% in 2 liters, actually wasn't hypoxic on room air, but everyone in the ER gets 2 liters of oxygen. On arrival, he was tachypnic, but otherwise he was pretty comfortable. He looked dry. And his workup in the ER showed he had an acute kidney injury and was actually in DKA. So his glucose was over 600. His bicarb was low because of DKA. He did get a CTA just because there was some concern with syncope and some shortness of breath for a couple days prior. So he got a CTA that showed a small segmental branch PE, but no RV strain. But he did have a large occlusive clot in his left leg, so extended all the way up to the common femoral. And this was at one of our outlying facilities where they actually don't look higher than that, but as far as high as they could see was occlusive all the way down to the popliteal. So the patient initially was in our outlying hospital in their ER and was transferred to the local MICU just in their own hospital. It took about 6-8 hours for the patient to get a bed from the ER up to the MICU, but was eventually transferred up with a diagnosis of DKA and a small low-risk PE. Started on insulin fluids and some heparin. Unfortunately, the case does not end there. Obviously, I wouldn't be talking about it. On arrival up to the MICU, the patient was clearly different. So the critical care docs who went down to see the patient in the ER when they initially got the call, he clearly looked different when he arrived up to the MICU. So when he arrived up to the MICU, he was very tachypnic, very hypoxic now, which he was not before, much more uncomfortable. They got a stat ABG, and you can see the lactate's now 17. So this patient has clearly changed. Gets resuscitation, goes to place the central line, start pressors, et cetera, resuscitation. And unfortunately, when they lay the patient flat to put the central line in, he goes into PA arrest. So codes for 3 minutes, they get ROSC, but unfortunately goes straight into PA again. So we have in our health system, we have something called a shock phone, which is essentially a 24-hour staffed critical care phone by a critical care cardiologist who anybody can call it, and they immediately get a cardiologist online down at main campus. Got the call and activated our shock team. The advice was that this probably was a transformation. That large clot in the left leg probably has moved and has gone from a low-risk PE to now a catastrophic PE with cardiac arrest. So they did not have ECMO there, and so the initial recommendation from the the critical care cardiologist they talked to was to give 50 milligrams of IV alteplase with a 2-hour infusion. We do have a shock mobile, we call it, or the ECMO car. So actually the shock team, we drive out to these centers. This one was 25 minutes away with a full ECMO circuit, ECMO cannulation tools, and cardiologists that go out and actually will cannulate ECMO at these facilities. So our mobile shock team arrived to the outlying facility. The bolus was given in alteplase. They had not started the infusion, but intermittent ROSC, but mostly PA arrest for that time. The decision was because he was young, otherwise healthy, the team thought he was a reasonable ECMO candidate, and so ECPR was done at our outlying facility. Immediately, the ECMO was placed and got a pulse pack, so we decided not to give that second 50 milligram alteplase infusion now that we had a pulse pack and on ECMO.
Can I ask a question quick?
Yeah.
Did you guys reassess for ECMO when you got there? Or, I mean, clearly by the time you guys got there, it had been a while. Our practice is, even if a code's been going on a while, I mean, reassess a lactate, a bicarb, and look at some of that stuff. Was that reconsidered or just with?
It was ongoing CPR, and so we talked about it before. It was a pretty healthy, robust.
Young.
We have a shock coordinator, so that while that team's driving out, the shock coordinator is calling the family, trying to get backstory. How is this patient? What is the medical history? How functional are they? Trying to gather medical records from other hospitals if we don't know about them. So our shock coordinator, by the time they got there, had found out the patient was a very functional person going into it. The thought was that probably had a small PE that triggered DKA.
Yeah.
Had a witnessed cardiac arrest in an ICU with good CPR, ongoing CPR, and did have intermittent ROSC 3 or 4 times during that, even though it was short-lived, less than a few minutes. Thought the patient was a reasonable ECPR save.
That's an incredible coordinated team effort that you have there. I mean, while you're driving, I mean, that's awesome. Yeah.
I would take credit for it, but it's not me. Now the question is, we have somebody who's a high-risk PE, catastrophic PE on ECMO. Just as a reminder, Per Consortium looked at this, 42% mortality in the patients with high catastrophic PE. And use of ECMO had an odds ratio, I think, of almost 3 or 4 for mortality in this series. So 48 hours are now still on ECMO. They're actually down on minimal pressors. They're starting to move and actually start to wake up. So they had good neurologic exam. CT scans showed no intracranial bleeding despite ECMO. There were no major vascular complications at this point despite ECMO and TPA, which if you look at some series, 60% of patients that get ECMO and TPA have massive bleeding complications. So 48 hours on minimal pressors, but unfortunately was unable to wean ECMO. So as we wean ECMO, we do echoes, and you can see here the RV is still not working. So CT scan was done at this point to see what residual clot and if the diagnosis was actually correct. We didn't know what the diagnosis was. We assumed it was catastrophic PE. And what you can see here is that there's still a large volume of PE in the right lower, the TA in the left lower. There is no saddle. It could have been that TPA actually worked. I don't know. But this is what we have left. Other view of it here. You actually see the ECMO cannula is probably too low. It's in the IVC, but so large clot burden. So our clinical challenge is we had a high-risk, massive, catastrophic PE, whatever you want to call it, who got systemic lytics, 48 hours, is on ECMO, and is unable to be weaned. What do you guys do?
Mechanical thrombectomy.
Yeah,
So-
you got to deal with the clot.
Still got to deal with the clot, right? So going into this, do you think, one of my concerns in patients who failed systemic lytics or failed lytics in general is this more chronic, right? The guy's symptoms have been going on for a few days. That clot been sitting there who knows how long. Is it collagen? Is it going to respond to lytics? So that was one of our thoughts going into it. The way I think about it is what are our options? And so, the patient is on ECMO. They're fully supported. They're doing pretty well neurologically. We could just stay on ECMO. There is some data for fibrinolysis on ECMO. There actually is a little bit of fibrinolytic effect from ECMO itself. They're on full anticoagulation. You can give more lytics, surgical embolectomy, and catheter-directed interventions.
I think the issue is your right side is still pretty obstructive. And in addition, if you were to believe the first CT scan from the other hospital, that was not there before. So it suggests that this is the embolic phenomenon from the residual DVT. I would probably favor doing something, especially since you've been on ECMO at least for a couple of days without any improvement.
And there is no data in this, obviously, very little data. So the largest series of failed lytics is about 488 patients, had about an 8% rate of failure rate. So they define failure rate as needing another intervention. 14 of the 40 patients got surgical embolectomy, 26 got systemic lytics in this series. Systemic lytics had a mortality of extra systemic lytics already after failed systemic lytics had a mortality of 40% with only 10% in the surgical embolectomy arm. So I think what I took away from this is that getting the clot out is needed. I think that if you don't respond to lytics, don't try lytics again. You got to get it out, whether that's surgical or mechanical. In our institution, we favor mechanical. This is just a reminder of the FLAME study, which was looking at high risk, 1.9% mortality with the mechanical thrombectomy arm. But actually, if you look at the study, only 3 people were on ECMO in the study. So although all 3 of them survived, can't really get much from that. This is Jun and Tarek and Mehdi's data, looking at 9 patients and a mechanical thrombectomy and ECMO. And they had a 90-day mortality rate of 22%. So really not much data to guide, but we thought thrombectomy was probably the way to go, just to remove the clot. This is the pictures here. You can see the right large obstructive, more distal clot, same with the TA, and also the left lower branches. Unfortunately, I took the T24 down, did a pass, got a blink aspiration, and then this is my next picture. After multiple attempts at getting that right lower, this is my next picture. So when you get blank aspirations, but there's still a lot of clot. You guys have any tricks?
For the right upper specifically, I've been using the 20 curve inside the 24 French straight. And this is the only situation I take the wire out, but before I take the wire out, I make sure my catheter where they need to be. So the 24 French straight will be far advanced. The 24 curve will be right where that right truncus anterior take off. And then I just take the wire off and sheath it, and then with some maneuvering that 20 curve can get into that right truncus anterior and can really do. I have done a lot of these specifically, and they come out very, when you have targeted just in that location rather than just being unselective, it makes a huge difference. The bottom one, I think you may just have to go get more wire purchase and just go a little bit deeper,
Yeah, I think you probably need to think about an oblique view too.
Yeah.
That's the TA looks pretty big. It looks like you could get the 24 in there if you want to just wire that. When you're working in AP, you lack another dimension, and sometimes with these branch vessels, you just need another oblique view.
I echo what they said with the curved catheter. You're dealing, like you said, I think pointed out well, this is likely more subacute clot. So even if you get down there, there's a chance you start ripping pieces off it and you're never going to be happy. Depending how bullish you were feeling, you could try to wire that past it with an 014 wire, a smaller wire, and use a small balloon distally and try to pull it back. I've not done that personally. I know some people have. Have anybody on the panel done that? To try to retract clot in a way, or like put a distal anchor in and be able to cinch it back in a way?
Yeah.
No, I've heard of people doing it, and I haven't done it myself.
No, I agree. Getting more wire purchase into that right lower area, and then I've actually had some success with their FT2, their new generation disc, to retract clot that I didn't think were going to come out. Essentially, it unroofs it from the pulmonary artery vasculature so that you can pull it out.
Honestly, the sucking power of that device is extremely powerful. So I think just sometimes patience and just more attempts. It's frustrating. Sometimes we have to do it 20 times to get it, and one time, some other times come out. So I think sometimes just some persistent, and just patience does the work,
That was all the thoughts going through my head. So I think those are great. I think the 24, my thought is sort of what Brian mentioned, is that if you actually look at the CT, that curve of the right lower is actually a little bit more 3D than it looks there. Mm-hmm. And so my thought was either it was chronic and I couldn't pull it out, or I just was not coaxial, similar to what you do with the left. When you try to take the 24 over to the left, you never get it. You always use the 20 curve, right? And so I never actually used the 20 curve on the right before this case. And I actually didn't use it in this case, but what I did was what you had talked about. To get more distal and to get more coaxial, I had to get more distal. And so I actually used the 16 sort of a mother-daughter way through. My two thoughts were, well, if the front end of it's chronic, maybe I get more distal and I grab the tail and bring it out, like you mentioned with discs, or in this case, I went more distal. And using that, I was able to get more coaxial onto the face of the clot, where the 24 just wouldn't get distal enough, and it was taking a bend. And so with the 16, I was able to get out, and surprisingly, it wasn't that chronic. It's kind of interesting. Except for the TA, you can sort of see is a little bit of a chronic component to it, but the rest of it actually was fairly acute. So why I didn't respond to TPA and was more challenging to pull out, not quite sure. So resolution, 36 hours, variable lead off ECMO, and was actually discharged 6 days after coming off the ECMO. This is the RV in our ECMO wean. You can see here the RV is almost back down to normal size. So learning myths, obviously high risk catastrophic PE is a high mortality. We tailor at our institution based on which facility they end up at. If they end up at main campus, we tend to go more ECMO thrombectomy. If it ends up in an outlying facility, it tends to be more systemic TPA. And then I didn't talk about thrombectomy and ECMO, but that's a talk for time for another talk. Thanks.
Thank you. All right, thanks for all those cases. Those are amazing saves. So we're going to change gears a little bit and talk about some novel devices, try to catch up a little bit on time disclosures. This slide is fresh off the press. I just updated it yesterday. So a few new devices on the 510K clearance that are now approved for PE in comparison to what I discussed last year. So obviously we know that the Thrombolysis catheters, the catheter-directed thrombolysis is available. Also AngioDynamics AlphaVac as well as Inquis Aventis catheter now as well. The IDGE trials that just completed include the Symphony catheter from Imperative Care and the E2 Halo Engulf trial as well, just completed in June. There are ongoing IDE trials, including Clean PE with Argine Cleaner Pro, the Quadra Acura Katana catheter, Spiro, the Jupiter catheter, as well as Trust and Nova Laguna. Trust is probably the furthest of all the IDE trials that are currently enrolling. They're about 50% complete. The other ones are relatively early in their enrollment. So a lot of things out there. We're like kids in a candy store. A lot of things to play with, a lot of things to choose from. So let's dive a little bit deeper into each category of catheters. I'm going to first start with large bore thrombectomy catheter. Obviously, with large bore, you want to optimize your delivery, you want to decrease your complexity in the procedural time, and you want to minimize your blood loss, as well as any adverse events, as we had seen already today. So first, I want to introduce the AlphaVac. This was the funnel tip catheter that opens up to a 33 French size in the very the opening of it. You unsheath in the area of interest of your clot, and you actually actuate using this mechanism to pull back. The blood then is collected into this bag. The the AlphaVac was approved based on this trial called Apex AV, which looked at a total of 122 patients. RV to LV ratio is improved at 48 hours post, as well as the modified Miller score. Interestingly, in their publication, there was actually a very nice comparison of the Apex AV against flare and extract studies. Here you can see that the clot burden removal was highest at 35.5% compared to the other two devices, Inari and Penumbra. The second device I want to talk about is the Aventis thrombectomy catheter. This is a fully integrated catheter that allows you to traverse two different branches of the pulmonary artery without having to do multiple wire exchanges and catheter exchanges. There's an inline blood return system that you can see here that's all integrated. So essentially it's a bloodless thrombectomy mechanism. I'm biased because I was the national PI for this trial. We actually completed this trial earlier this year. This was presented at SCAI Scientific Sessions in May. We had 120 intention to treat patients over the course of our study, and dramatic decrease in RV to LV ratio as well. And I would like to point out that the refined modified Miller score was decreased at 35.9%, even exceeding the Apex AV trial. Importantly, no device-related major adverse events at 48 hours. This was our very first IDE trial looking at quality of life improvement at 30 days. What you can see here is that there was improvement not only in the score of quality of life, but also 6-minute walk distance in all of our patients. If you'd like to hear more, we are having a lunch symposium today in room 1. Imperative Care Symphony is the catheter one of the catheters that's just finished their IDE trial. You can see that this is a mechanical thrombectomy device that comes in 24 French as well as 16 French. There's a high-powered continuous vacuum along with an ingestion mechanism. So we do look forward to those results. Laguna from Innova is essentially a cage system attached to a large bore thrombectomy catheter that also performs aspiration. What you can see here is kind of similar to what we discussed. The cage itself brings the clot into the catheter, and then you perform the thrombectomy that way. This was an interesting concept that I found. This is a clot hound. This is a video showing this device essentially macerating a chicken liver that was stuck inside this clamshell. So the intention of this device is actually to essentially mechanically macerate some wall-adherent clot. This is not currently under trial yet, still under investigation. Althea Medical also has a 26 French thrombectomy system that has an 8 French mechanical component. You can see the kind of the Archimedes screw-looking device that's attached to it, and also an aspiration port. Moving then to the medium bore devices. Let me back up here. So again, with medium bore devices, these are the generation that's kind of in the 12 to 18 French category. You want to, again, optimize delivery. You want to decrease the complexity of the procedure as well as the time, enhance safety, and minimize your blood loss. E2 Helo thrombectomy device has a canister area that opens up to a 24 French with an agitator inside. Here you can see the agitator built inside this funnel. Essentially, that helps with the thrombectomy and makes it more efficient. Again, this trial just finished their IDE enrollment. This was the first in human presentation that was presented at SCAI a couple of years ago, showing RV to LV improvement in their first in human experience. Acura, actively enrolling IDE trial, similarly has a funnel that opens up to 30 French. You can see there's a lot of repetition in the designs of these catheters, but essentially this is a smaller French catheter with a mechanical component that also opens up to a funnel. So the funnel, again, allows you to latch onto the clot for more efficient thrombectomy. Primary endpoints, you can see this was also a first in human data performed in the Republic of Georgia with a reduction in RV to LV ratio. Argon Cleaner Pro is a catheter that is an 18 French mechanical aspiration system. This is a case from one of our sites that performed thrombectomy of the right lower as well as the left lower lobe. And you can see the clot that was withdrawn from that. A couple of other interesting catheters out there that haven't undergone any IDE enrollment yet. The Expanse Medical ICE catheter actually uses a water jet to help improve the aspiration, the mechanical aspiration of clot into the catheter. And I'm sure you've all seen this, the Magneto E-Trieve, which uses electrolytes to essentially dislodge the clot. But there is actually a thrombectomy, an aspiration component to this as well. You can see here by the syringe that's attached. The first in human was performed in 2023 in European sites, and you can see the associated procedural data. The RV to LV ratio, similarly, like everything else, drops at 48 hours. The E-Trieve 2 is not yet recruiting, but they do have a associated clinical trials report. The Ono catheter is a 12 French system that has this cage out here, perhaps with the intention of targeting more organized clot, more wall-adherent clot, and clots in transit. Lastly, let's talk a little bit about catheter-directed thrombolysis. So catheter-directed thrombolysis, the intention is really to balance the dose of TPA and essentially administering effective therapy, but balancing it with a bleeding risk. With these catheters, ultimately what you want to do is try to shorten the time of therapy. With our thrombectomy catheters, we try to perform the procedure on table. You finish the case, patient leaves the cath lab theoretically with a reduced burden of clot. But one of the criticisms of catheter-directed thrombolysis has been the extended ICU stay. So there has been some movement towards shortening that obligation. So let's talk first about the Thrombelex Bashir catheter. This is a nitinol basket, which has 6 struts with an infusion port. Unlike ECOS, which is a ultrasound-assisted catheter-directed thrombolysis, this cage actually just then sits across your clot and infuses the TPA locally. The first trial was called Rescue, which did, obviously, like everything else, show the RV to LV reduction. On-table treatment was studied in Rescue 2 with a total of 9 patients. And essentially what the operators did was infuse the TPA on the table, measure the PA pressures, and then take them off the table. So no long-dwelling catheter was used in Rescue 2. Interestingly, despite that, the RV to LV ratio at 48 hours showed a 22.3% reduction, as well as a modified Miller score reduction of 29%. The rapid PE is a trial that is currently ongoing, again, looking at on-table infusion of TPA using this catheter. Lastly, the Flow Medical device is very similar to Bashir. However, so it's a cage that you put across the clot and you infuse TPA, but there is actually an additional fiber optic sensor that allows you to monitor real-time pulmonary pressure. So theoretically, you can park your patient in the ICU, monitor their PA pressures as you're performing the treatment, and once you see that the pulmonary artery pressures have decreased, then you know that the clot has lysed sufficiently to allow distal perfusion, and hence knowing that you can actually withdraw the catheter. My slide is not advancing. Can you advance? Thank you. So in conclusion, there are many, many devices out there that are undergoing investigation. And the primary goals of these new devices ultimately is to make the procedure faster, easier, and safer for our patients. However, let's not lose the forest for the tree. These clinical outcomes remain very important. So not just RV to LV ratio, we have to think about the patient quality of life, any mortality benefit, if any, using devices compared to medical therapy. So shameless plug for other trials that are ongoing. HiPytho, Peerless 2, Storm PE, and PE Track are all trying to look at the use of thrombectomy or catheter-directed thrombolysis devices against heparin anticoagulation. So we do look forward to those trials. Thank you.
All right, Jun, as co-moderator, I get to ask the hard question. So many devices coming, get into candy store. 2 questions would be, what does your ideal device look like? And then second question is, what does it look like? What does the landscape look like 5 years from now, right? Are we gonna have 1,000 devices on the shelf? Is this gonna be a one winner wins the race? How do you see it?
So, I'm usually of the opinion that it's actually a little bit tough for us to change, right? I think we're all kind of, we're very used to things that we do. So ultimately, I think it's all of us kind of depend on one bucket that is our go-to, right? Mm-hmm. For myself, it would be a large bore thrombectomy. For you, it might be something else. So I think it's hard for us to change buckets once we've been doing these kinds of procedures for years, so we're familiar. So I think ultimately, at the end of the road, likely we'll have a couple of catheters that fall within each bucket. And I think if I were to predict 10 years from now, that's probably what's going to be the landscape. I wouldn't think that you would necessarily stock 10 different catheters to perform the same procedure in one hospital. Economically, it doesn't make sense. So ultimately, I think the catheters that outperform others in terms of ease of use and safety profile will probably win. Others?
I think your last point is fantastic as well. All these studies and the way that these devices are getting approved are by using RV-LV ratio, because it's the gold standard we have from the 90s, early 2000s, right? But I think your point of these clinical outcomes are really important, and where our focus has to come to. What device? How do we? The question to the panel, which I think should be a topic for next year. How do I know when I'm done? Because we still don't know, right? And I think that the nuance to what you were talking about and what you laid out so well in this is that I think where we're going with this field is what device is best for which patient in which case scenario. And I think that we will continue to evolve and hopefully be better at that over the next 5 to 10 years as well.
Yeah, I think once the data and experience allows us to move past acute outcomes and to really look at kind of how we're benefiting people in the acute setting, but also 3 months down the road, a year down the road, 10 years down the road. I think that's kind of the holy grail for really moving these catheter-directed therapies into kind of the mainstream. And I think the only way to get there is with a lot of those studies that Jun mentioned.
Great. I think we'll move on for time. Next is Brian Stegman, who's going to give us a case of mechanical support in PE.
All right. Thanks, everybody. So I'm going to talk a little bit about mechanical support in PE. I'm just going to give a little bit of an overview. Sam actually gave probably a better overview than I'm going to give. And then we'll go through a couple cases. So my name is Brian Stegman. I'm an interventional cardiologist at Center Care in St. Cloud, Minnesota. All right, so high-risk PE. All of us that do this, these are the cases that, we're always scared of, right? Defined by patient with a PE and a cardiac arrest and obstructive shock requiring vasopressors or prolonged hypotension. About 5% of the PE population, but the sickest of the population. There's varying series, kind of going through various mortality numbers, but what I have up here, in older series, 58% mortality at 3 months. So a very mortal problem. So what's the pathophysiology? So obstruction leading to pulmonary vascular resistance increase, pressure overload, RV is weak, and dilates, you get subendocardial ischemia that leads to further dilation, further dysfunction of the right ventricle. You get septal shift. With septal shift, you get less LV output, and so now you have poor RV flow through the pulmonary vasculature with a sick right heart and an LV that's not filling appropriately, leading to kind of a cascade of events that ultimately end up in cardiogenic shock. So management. So I think with this, you kind of put management into buckets. So what happens in the first 10 minutes of the patient getting to the ER? That's volume resuscitation. It's vasopressors if they need it. It's calling the right people, getting the right people involved. What is the best treatment option for the person? I honestly think this is put into kind of two categories. So I think part of it is what time do you have? Is this a patient who's on 10 of norepi and 8 liters of oxygen, but are kind of hanging in there? Do you have some time? Is this somebody who's arresting in front of you? And also, what time is it? Is it 2 in the morning or is it 2 in the afternoon? If it's 2 in the morning, I can't speak for any other hospital but our own, but I can't get somebody to the cath lab in 10 minutes at 2 in the morning. And so, that's where I think systemic lytics have a good role. These patients who are just so sick immediately have refractory arrests or that you can't mobilize things as fast as you perhaps want to. And then I think the other thing that we have to talk about a little bit is kind of site-by-site variation. What's your comfort with ECMO? What's your comfort with alternative mechanical support strategies? How fast can you implement those things? And everybody's a little individual in that. So I think it's a little hard to say what the best treatment for the patient is universally. It depends on where they are and what you can mobilize quick. I also think that it's important to mobilize. So doing everything as fast as you can, getting the right people involved as fast as you can, and also making sure that you work in parallel and not series. This is something that we talk a lot about in the various realms, structural being one of them, but not doing things, A doesn't lead to B, doesn't lead to C. You have to be mobilizing people all at the same time and make sure that you can do things quickly. And in these patients, you got to manage their hemodynamics, but also manage their clot. So there's kind of a few options now for mechanical support in the folks who require it. VA ECMO, Sam talked a lot about and gave a really nice review on. RP Impella does also, get used in these patients. I actually have a fair bit of patients that we've used this on, and we'll talk a little bit about that later. The data's, there's not a lot. Protect Duo is another option, gives you RV support, also gives you oxygenation, but both of those things require that the clot be dealt with. VA ECMO doesn't. So what's the data? So this is from a review from Texas Heart back in 2020. VA ECMO, they had 164 patients that they reviewed, looking at, it's kind of a meta-analysis, and 120 survived to hospital discharge. When they looked at the alternative types of mechanical support, in this it was RP Impella, Centromag, Protec. There were very few case instances, case reviews. There's, in this review there was 8 Impella patients. All 8 survived. Hard to know what to do with that. It's such a few number of patients. So the data is really lacking in this. So VA ECMO has the best data. This is a relatively recent systematic review. 301 patients. Again, 60% survival to hospital discharge, but showed increased risk of death if you're greater than 65. Increased risk if you're actively arresting when you do it. That all makes sense. Sicker and older patients are sicker and older. And so, what are options? How do you kind of work through this? So this is how I think about it. VA ECMO, you get essentially biventricular support. You get full systemic support. You get perfusion. You get oxygenation. You also unload the RV. And it provides you time to deal with the clot burden. The disadvantages is large bore arterial, large bore venous. Its availability is limited somewhat by center comfort and size. And you also do increase the LV afterload and bring in a large arterial sheath into or cannula into the equation, so you have a risk of limb ischemia that you don't with the other devices. RV assist devices, so unloads, supports the RV, kind of treats the RV problem. It's a single venous access. That's nice. It can be a little less resource intensive and staff intensive and maybe more available, but does require, at least in the RP Impella, requires that you deal with the thrombus first because it does not treat the hypoxia, and a high systemic or pulmonary resistance circuit doesn't work in. So let's go through a couple cases. So this is a 74-year-old. They were admitted to the RER with shortness of breath, CTPE, study bilateral PE, RV-LV ratio 1.3. They were tachycardic in the 130s, requiring 5 liters of oxygen. We did thrombectomy that day with good result. He went out to the floor, was doing great, got a DVT ultrasound, had fairly extensive DVT in his left iliofemoral system. We were talking about putting an IVC filter because of how bad his RV was, or just medical therapy. While we were kind of discussing it and figuring out what to do, he all of a sudden developed acute onset shortness of breath, VA arrested, ACLS. He's getting, so our PE coordinator called me. I was in the cath lab, ran over to the CICU. Guy's getting CPR. This is, to give you some context, this is our angio after our initial procedure. So you can see pretty good perfusion everywhere, not a lot of clot burden left. So this guy is getting CPR, but has had intermittent ROSC. He's now getting transferred to the cath lab. He's on a little bit of epi, getting little pushes. Panel, what do you do?
Go ahead.
Yeah, I think this is a case for ECMO up front. I would have done ECMO because you're right that if you truly believe this is massive PE and the clot has not been dealt with, it's going to be very, almost impossible to put the impella and do the thrombectomy at the same time. So if he's requiring pressors, arrested, I would think, this is an ECMO up front case.
I think that's what most would do. That's not what I did. So this is all a site-specific thing, right? So this is the guy's angiogram of his right PA. Looks like I'm locked up. Okay, there we go. So emergently took him to the cath lab. We activated our ECMO team. We had the perfusionist coming up. We always have a pump primed, but it does take a little bit of time to mobilize people in our site. I think in others that do ECMO more, it's probably faster. I got access. I took a picture. We're giving him intermittent doses of epi. This is what his right PA looks like. And this is what his left PA looks like. So he's had fairly extensive clot. At this point, he's getting little pushes of epi, but I thought, I'm in there, let's just go deal with it while we're getting everything mobilized. And we'll kind of see how this goes. We'll decide if we're going to do ECMO, if we're going to do an RP, depending on how fast we can get this clot dealt with. So this was our post-thrombectomy of the left. Looks pretty good. Post-thrombectomy of the right. So we got pretty good flow.
Brian,
At this point,
quick question.
Yeah.
Before you went in, did you take a picture of the IVC?
I did not.
Presumably, it came from that residual DVT.
Yes. Yep.
That may be important to consider, especially if there's contemplation of ECMO, is whether or not your IVC also has a clot that hasn't embolized yet.
No, that's a very fair point. So,
You just pushed a 24 French catheter, so you probably brought it up with you if there was. So, he had all left ileal femoral DVT on our initial scan. We do ultrasound access on everybody. There's nothing in the right system that I could see. But yes, that's a very good point.
Especially for ECMO, because it's happened before that you turn ECMO on, there's a clot in the IVC, it gets sucked into the ECMO, and your ECMO then clots, and then you're in an even more emergent situation trying to change out an ECMO circuit. So with Jun, I'd push for an IVC gram if you're going to put ECMO in.
Yep.
If you have the time.
I did take a quick ultrasound of the left system, and there was no clot, at least in the common femoral or femoral vein. Presumably it was all in the lung.
Was TPA considered, Brian, or there was a contraindication? Sorry, I missed that. Was TPA considered?
It was considered. So this was at about 1 p.m. I was between cases. We had a cath lab open. It took us about 5 minutes to get the guy over there, so we decided to do that. We thought we could probably deal with the clot faster than using systemic TPA in this way.
Yeah, I guess the time was the daytime because, if it's nighttime, probably you and the ECMO team would arrive at the same time, but if it's daytime, probably would be. So you activated the ECMO, you thought about it, but you were, just because of the delay, you proceeded with the thrombectomy.
Yeah. So, and this is, again, all site-specific stuff, but really, being in all honesty, for me to go from patient wheeling into the cath lab to me having them cannulated on ECMO because of what it requires in our center, it's probably going to take me 25, 30 minutes. And I felt like I could probably get everything out in that time, provided that he kind of dealt okay with it hemodynamically. So we got all the clot out. Our angiogram looks good. Our patient, unfortunately, doesn't look good. He's still requiring vasopressors. He's on 2 pressors at this point. He's got severe RV dysfunction on our little bedside echo. So we decided to put an RP in, and then you see the Swan catheter beside it. So I put the case times up here just to kind of give you some idea of, the timing here. This person rolled into the cath lab at 3:10. They left the cath lab at 4:20. So, for us, it was just, we felt like we could kind of get this done faster this way. So what happened with him, he continued to require 2 vasopressors. Those cardiac index normalized. This is his lactate trend. So 14.7 was in the cath lab when we got access. After 36 hours, it had normalized. He was off vasopressors at that time. We weaned the pump, pulled the pump on day 2, and extubated on day 5, and discharged to rehab on day 10. So he did very well with this. ECMO would have been a very reasonable way to go, I think. And I think what most centers would do, I think for us, these are decisions that I think you have to decide what your site can do and what's kind of best for you. So one other quick case.
Just a quick question. After you place the RP impella, how do you decide that's enough before you have the patient leave the lab? How do you decide, do I need further escalation to full support?
Great question. So what I generally do is I will get a mixed venous sat when I place it, and I let them sit for a little while. They'll be on the table for, 10, 15 minutes. And we get another sat if we're improving, if our index is improving, if our vasopressor requirement is decreasing, then I think we're probably in a good place. If it's not, then we will think about escalating.
So PAPI's not really been studied, obviously, in this realm. Have you seen any use of PAPI as an adjunct to understand whether or not it's enough for your RV?
So I think PAPI is very useful in 2 scenarios. So you can't use it once you have an impella in, obviously, because it kind of all of the, because of the continuous flow, it changes that. But I think in the folks who you're not exactly sure how sick they are, their cardiac index is poor, their RV looks bad, but they're kind of looking okay. PAPI is often will help me make the decision of do I want to do a little anatropes after a submassive PE or not. I think in these cases, arresting on vasopressors, getting epi, I'm not sure how useful it is. All right, well, I think I'm about out of time. Let me just take 3 seconds for this, because this is exactly what I think illustrates the utility of ECMO. So 46-year-old came to our ER, severely short of breath, initially 10 liters, had a respiratory arrest, PEA arrest. They called us after doing CPR for about 25 minutes on the patient. They put a Lucas on, and we took him quick to the cath lab. This was somebody actively on a Lucas, 40-year-old woman who had got lytics. She still has some residual clot. This one, we decided, okay, this we have to have ECMO. This also, we had a little more time late because we're in the emergency department. We had to get them up there. We could mobilize. We had enough time to mobilize, and I didn't think that I could get thrombectomy done quick enough. So this one we did ECMO up front. This is after our thrombectomy on the left. After we placed ECMO, this is her RV after thrombectomy, and with the ECMO cannula in place, and her hemodynamics improved. She decannulated 2 days later and was extubated at 5 days and discharged at 9. All right, so I think quick thing, take home is what we've been talking about. It requires multidisciplinary care. It requires you to understand what your site's capabilities are, and also to understand kind of that and admit that there are different things that can be offered at different times, and just being very sensitive to that.
Thank you.
Thanks, guys.
In the interest of time, let's invite Dr. Shishehbor up, who needs no introduction. He's going to present on clot in transit and vegectomy. Thank you.
All right, well, thank you so much. Very nice and informative session on, thanks, on PE, and we're gonna move it here to the tricuspid valve. One of the beauties of emerging technologies is that as they come to practice, they allow us to do other things that we didn't think of. I want to give all the credit here to Dr. Tarek Hammad, who actually made these slides and has done a lot of this work with me in collaboration. So you'll see what happened. So the bottom line is that, what do we do with endocarditis? As you know, we are talking about the right-sided endocarditis. And I know there are some case reports out there, somebody done something on the mitral valve, somebody has done something on the aortic valve. I think those things seems to be a little bit out there. The focus of my presentation is really on the right-sided, which is very challenging because these patients usually get endocarditis because of IV drug use and occasionally because of dialysis and those kind of things. So the management cannot be just valve-specific or endocarditis-specific. You have to also worry about compliance, recurrence, and many other challenges. And the treatment historically for this patient has been surgical. So I have it here for you what the recommendations are. There are really two categories, one related to the valve, to the tricuspid valve. The other one is related to the devices. And you can see that the recommendation is that if the organism is there for more than 7 days, or if the size, which are the historical recommendations for endocarditis, that if the size is big enough, or that the organism is not able to be cleared by antibiotics, you should consider intervention. And historically, these patients get a sternotomy. So they get their chest open, the surgeon goes there, removes the vegetation. In many of these cases, the tricuspid valve is completely destroyed. They have to put foreign material in there. And then what happens a year later, 6 months later, the patient comes back because we haven't dealt with their IV drug use and other challenges that they're struggling with. And the surgical outcomes have been all over the place. You see here, it says, the percentage of cases that were being performed for endocarditis range in different reports from 5 to 40%. The mortality, and this is published data, is between 15 to 20%. And many of you who practice in a hospital, you know that these are usually young patients. They are usually have failure to thrive. The albumin is 2.2. They are not the greatest surgical patients because unfortunately many of them have not taken care of themselves, or in some cases, they have a lot of comorbidities that have led to their endocarditis. So it's a little bit better for the devices from the standpoint of outcomes, but the challenge with the device-related endocarditis is that the devices also have to come out. So we have had this struggle in this field because the interventions have been, the recommendation is very invasive, surgical sternotomy. So about 10 years ago, we had a very young female that had extensive fungemia, multiple weeks of management, very high risk for surgery, EF of 10%, and so on and so forth. And at that time, we were like, is there a percutaneous approach to be able to treat this patient? And at that time, the only device that was really available and was not actually used really for vegetation much, was being used mainly for clot, was the angiovac system. So we used the angiovac system at that time, and we went in with the angiovac. And remember, this was not a tricuspid valve situation. This was a lead-related endocarditis. So with the help of the angiovac here, and this is the device right here, and there was you see there's a little bit of a curve here. The good news about this was that the vegetation was so long and so big that was extending into the SVC. So using TE guidance, using the angiovac system, the vegetation was somewhere around here, and then lead extraction. We did simultaneous lead extraction and vegectomy in this patient, who ended up actually doing very well. She was 23 years old at the time, and we published the work. That was over 10 years ago. And this is the kind of the data about the angiovac. Is a very invasive system. And honestly, the complication from this technology is pretty high. This is a meta-analysis of 42 studies, and you can see the rate of conversion to open surgery was 25%, and the mortality from the device since that time, not specifically used for endocarditis, used for other indications like PE and so on and so forth, is not minor, as I have shown you here. So with that, I want to take you to this case. This was a 65-year-old male. As we were trying to evolve and these devices were coming out for PE, we noticed that maybe some of these devices can be used to treat tricuspid valve endocarditis. So this was a male patient with IV drug use that has come in with endocarditis in moment tricuspid valve. And this was the lab work. I don't want to waste too much time on this aspect of it. Just take my word on it that this was a persistent bacteremia and tricuspid valve endocarditis. And the discussion was that, well, what should we do about this patient? And this, you can see it, I think the pictures speak 1,000 words. As you can see in this case, the patient meets the criteria for surgical sternotomy, both from the standpoint of size of the vegetation and the persistency of bacteremia. And this was a little bit older patients. Usually, like I said, these patients come in their 30s and 40s. This was 65-year-old. So the question was, in communication and collaboration with our team, Dr. Hammad, myself, and our cardiac surgical team, is there a percutaneous approach that we can use to do this? And this patient was very sick. The idea was that, can we do this in an awake patient, not to use TEE, and do it really minimally invasive way? So we came up with this technique. Tarek and our team, we came up with this technique. We said, well, why don't we use the ICE device? So this is the ICE catheter going from the same groin, utilizing the ICE catheter and right here, and using the 24 and the curved Inari device, be able to get into this area and taking advantage of the curved catheter and the 24 to try to shape and be able to reach the tricuspid valve. The challenge with most of the current devices that are out there is that they're straight. And you can't get to a tricuspid valve, which is here, if you have a straight catheter. And we don't have any the morph catheter and other catheters that are out there that some of our structural folks use. They are not big enough. We need a much bigger size, 20, 24 catheter to be able to get these large vegetations out. So we basically are using two catheters here, a smaller 20 curve and a 24, to try to shape how far we can reach into the tricuspid valve and get close enough. And we're doing this under the guidance of angio and ICE. So the patient is wide awake, there's no TEE, and it's done in the cath lab. Can you advance for me, please? So we started the work here, and we can see sometimes the beauty is that how stealth and intentional we can be with this procedure. So it's not like we have to go get the whole thing out. We can actually take piece at a time. And here we went to work, and we got these pieces one by one out of there. And this was our first case. So we were also learning some, how to do this and figure things out. I think we have done over 100 cases now, at UH. For this kind of indication. And this is basically showing you the ICE images after the vegetation was removed. It's actually impressive, honestly. We actually surprise ourselves that how much we can remove from doing this procedure. The resolution of the patient subsequently cleared his bacteremia and was discharged to a skilled nursing facility without a sternotomy. And the beauty, honestly, the motivation for me for this procedure and our team was that to give an opportunity to these patients to undergo rehab, to undergo evaluation, and get the treatment they need. If we damage the tricuspid valve, which we haven't really seen much, if you agree, if we damage the tricuspid valve, at the time we were thinking, okay, even if we damage the tricuspid valve, meaning that because of the suctioning, we could then have a surgical intervention down the line once the patient drug use and other issues have been addressed. But we buy some time without having to perform an invasive sternotomy and put foreign material in the patient. And like I said, we've done over 100 cases right now. Majority have been on the tricuspid valve, but we have had also lead issues. And we have a great collaboration with our electrophysiologist. Sometimes we do it simultaneously. Occasionally we go in there, we take out the vegetation, we then have them do the lead extraction. It's sometimes too many people in the room, so we just like to do our thing and just hand it to them and let them do the lead extraction later. And honestly, we have had one complication, which has been a minor growing complication. So it's a very safe procedure. There shouldn't be any perforations or death from this because you're doing it very carefully. You have both fluoroscopy and echo images to guide you through the process. There shouldn't be any aggressive pushing or pulling of catheters. And like I said, even if you're not able to take the whole thing out, if you're able to debulk the vegetation and get the bacteremia resolved, the patient that can be treated in a timely fashion, electively, for whatever that's necessary. And Tarek did all the work. He published the work. This was the first published case of doing a live, awake patient using ICE catheter, a 4 and the 24-20 curve in RE devices to get the vegetation out in these patients. Anyway, I think that, it's all about collaboration. I think there are other devices that are now out there that can do this. I know Tarek has experience. Maybe he can talk about it using other devices. And I think there are going to be other technologies that are maybe make it even easier to get to these vegetations. Sometimes with the curve, we're not able to get far enough, especially if there's dilation of the RV. But we are learning more, and I think that this has been an amazing journey for me, honestly, from the standpoint of patient-centric, being able to help patients that are very sick, very young, and preventing a sternotomy and open heart surgery in these patients. Thank you so much.
Great case. Any input from the panel? Have you guys tried these kinds of techniques for vagectomies in the tricuspid valve?
So we've done a fair bit. We've generally used the AlphaVac as our kind of go-to.
Alpha or angio?
Alpha. Oh. Yeah. So yeah, we actually don't even carry AngioVac. We just use kind of AlphaVac for all this stuff. But we've done a few tricuspid cases. We've done probably 2 or 3 mitral cases and 5 or 6 aortic valve cases. I think a couple important notes on that, the left-sided stuff, especially the aortic valve stuff, it's a longer way from the groin, so you can't usually use the big device. You have to use the PE device to have the length to get there. For the tricuspid, the mitral devices, the bigger AlphaVac works very well and has a lot of, to Mehdi's point, has the ability to kind of create a full, nearly 180-degree curve if you need to, because that's really what's important in these things.
Yeah, and I think being able to interpret your ICE images is an important skill set for those who do endovascular. Obviously, our structural colleagues are well versed in ICE as well. When we first kind of started doing it in our institution, I had to learn ICE myself so that I could target the lesion. But it's actually a really kind of fun procedure. We involve the cath lab nurses. They're usually sitting at the ICE ready to snap our picture for us. So I think it's actually a great procedure, and the patients really benefit from having not to do open heart surgery.
It's actually been interesting that, our cardiac surgeons are our biggest referrals, because obviously these are not the kind of patients they are looking forward to do a sternotomy on. So usually we get our phone calls from our cardiac surgeons that are like, oh, there's a patient, in the ICU. Can you consider this patient for a vagectomy? Because, we don't want to do so. Tarek, you have experience with AlphaVac also, and your thoughts, anything in general, because you've done a lot of these.
Yeah, thank you, sir. Yeah, I've done, I think, 2 cases with AlphaVac. It worked very well, but honestly, because we have done so many cases with this device, Inari, I'm very comfortable, and especially if, with time, we evolved to learning to use the way the ICE is looking and your fluoroscopy. So what I like, the ICE is like my phone. So the imaging is this. So if you get it in a way, whatever the ICE is looking, but move your eye to a way you see your eyes this way, so you know exactly it's perpendicular. So I think we evolve in the way we do it, and I feel like, even though I love the AlphaVac, but I feel like I'm so comfortable now with the Inari that I'm not even willing to change. It's like, and usually
goes back to your point. Once we get used to something, it's hard to change.
Yeah, it's like a quick half an hour becoming. We used to spend some time. I think now it's becoming a quick half an hour procedure, and patients out of the lab.
Yeah, it's pretty amazing how quickly you can, consider the alternative. Dr. Castro. Dr. Castro Dominguez is asking, what kind of protection do you use for left-sided vagectomy?
So what we have done in the past is use Sentinel for the innominate and the carotid, and then we will put a balloon up in the subclavian when we're aspirating.
Right.
We'll take a quick angiogram of the Sentinel before we retract it to make sure that there's nothing bulky in there before we retract it.
Have you cut any material?
We've caught material. We've never had to go aspirate out of the actual Sentinel device. It's always just been kind of small stuff. What I think has been very surprising about this, and I was very, very reticent to do this, but we just had some patients that just didn't have any other options. And I've been surprised at how well the aspiration actually works and how you tend to get the vast majority of things. You got to be very careful and do your due diligence in protecting against distal embolism, but it does a surprisingly good job of getting most things.
And how about blood loss? Because I would imagine even in this area, there's a lot of blood loss even on the right side. So what are you doing about the blood loss?
The blood loss in the arterial system?
Right, because you're sucking back and the blood is coming out and so on and so forth.
Yeah. So you have to do it a little bit differently because it's a pressurized system, so you have to kind of hold the valve closed. And you can do that with the device. If you don't do that, then you will lose more blood. I think in the vegectomy type cases, blood return may not be the best option. I think in the clot type cases, doing it like a PE and returning it through the venous system after filtering is what I generally do.
Okay, great. Is that okay if I close this session? Okay. For the sake of time, I think we're going to close this session.